Hello, my name's Chris Walker, and I'm here today with two esteemed Italian professors to discuss medications efficacy for treating knee osteoarthritis in older people. I'm here today with Professor Veronese and Professor Maggi, and I'd like to offer them the opportunity to introduce themselves by explaining a little bit about the research that they do in osteoarthritis.
I am a geriatrician by training, and I work mainly on epidemiology of older patients there for disease, chronic diseases, and in particular osteoarthritis. So I have carried out observational studies and some randomized clinical trials over the course of my career on osteoarthritis, focusing mainly on the functional impact of the disease and its treatment.
I believe that my research is also epidemiological. Practically, I work at a database level in order to search when it is important to detect knee osteoarthritis and how this condition can worsen the quality of life, for example, in older people.
Thank you, professors. That's an excellent introduction. And between the two of you, you provide a very broad perspective in relation to the different aspects that we need to consider in treating populations and individuals with any particular chronic disease. So thank you for that introduction. Right, without further ado, we're going to follow the same format. We're going to ask 5 questions in relation to the effectiveness of treatments for osteoarthritis. Paracetamol is widely used in older patients. Is it efficacious for controlling knee osteoarthritis symptoms?
Okay, I believe that first of all, we must remember that increasing literature is reporting that paracetamol is not as safe as we believe. Moreover, it is important to remember that very important literature has reported that paracetamol has really a minimal effect on pain, which translates practically to not detectable clinical effect when compared to placebo.
And I would like to add that it should be also reported that paracetamol has no significant effect on stiffness and motion in older patients affected by knee osteoarthritis. And these aspects are extremely important in older people since they are highly associated with declining physical function, therefore frailty, and increased risk of disability.
Are fixed combinations of glucosamine and chondroitin sulfate useful for treating knee osteoarthritis?
Well, if I might, it has been widely reported that fixed combinations of glucosamine and chondroitin sulfate fail to demonstrate superiority over placebo in terms of reducing joint pain and functional impairment. And this is plausible actually because chondroitin sulfate is known to interfere with the absorption of glucosamine, reducing its bioavailability by 50 up to 25%, and therefore limiting its clinical effect.
Fully agree with Stefania, of course. I'd only like to add that another important problem is that the fixed combination of glucosamine and chondroitin sulfate are often products of low quality and, in particular, poorly controlled by regulatory entities in Europe and in America. Therefore, their use is not suggested by any current guideline regarding knee osteoarthritis.
Thanks to you both. Is there clinical evidence of multimodal pharmacological interventions being successful in knee osteoarthritis treatment?
So, first of all, I'd like to remember that for multimodal intervention, we mean the association of 2 or more approaches, pharmacological and or non-pharmacological, for treating any osteoarthritis symptoms. In particular, when talking of pharmacological approaches, I believe that one of particular interest that is increasing is the use of CISADOS, for example, glucosamine sulfate, and oral NSAIDs. That is also a common approach in my daily clinical practice.
Yeah, and I think that we could say in this case that 2 is better than 1. And In fact, the concomitant use of oral NSAID, such as meloxicam or celecoxib and glucosamine sulfate, gives better results in terms of pain controlling, and probably because of the anti-inflammatory action that is more evident with a multimodal approach than not using the single drug.
Thank you. Moving on to NSAIDs. Are all NSAIDs the same in terms of benefits and risks that they are associated with?
Well, I would say that they generally been shown to demonstrate equal efficacy to each other in the population of osteoarthritis patients. And in older people, however, we must remember that side effects are more frequent compared to younger patients for several reasons, such as the polypharmacotherapy or the presence of comorbidities such as renal failure that can interfere with the normal NSAIDs metabolism. Therefore, highly recommended to better understand the possible risk side effects of this class in older patients.
So I believe that it is extremely hard to answer to this question. I cannot say the best, but probably I can say that the worst oral NSAIDs that we have, that is, thank you God, not available in many countries, is probably rofecoxib. Rofecoxib, we have several meta-analyses, of course, based on randomized controlled trials and other kind of studies, suggesting that alone can increase the risk of cardiovascular disease for all the class. So the literature that we have available so far indicates that celecoxib, for example, may be probably the preferred oral NSAID or non-steroid anti-inflammatory drug, probably due to a good balance between the short-term efficacy and the risk of side effects. Of course, please again have in mind that it can have some side effects, for example, at gastrointestinal level. However, in my opinion, in the balance, it is reasonable as a balance between pros and cons.
In relation to total joint replacement, I appreciate that's the final solution, if you like. Does that provide good levels of efficacy, or are people still in lots of pain after the intervention?
Thank you for the question. So I believe that total joint replacement is overall a good intervention for improving pain, function, quality of life, also when applying to older people. So total knee replacement is appropriate, particularly when all other treatments modalities have failed, and if the patient is really severely symptomatic. And please take in consideration the importance of loss of quality of life.
Well, yes, definitely, Nicola, I agree. And I think that even if the total joint replacement can be considered highly effective for advanced knee osteoarthritis, I think we have to focus our attention to the possible contraindication in older people. As usual, older people are at higher risk for physiologic risk and surgical complications. And also hospitalization per se in older people is a risk factor due to the immobility and therefore again to the increased risk of sarcopenia and loss of physical function.
Thanks to you both. That's an excellent summary of the different treatment options that may be tried in individual patients and populations for the treatment of osteoarthritis. From what we can take from that is some treatment options have more evidence for effectiveness than others, and some may be suitable for longer longer courses of action, longer courses of treatment than other medicines. So let's move on now to the final video capsule. Thank you for your presentations.
Thank you.
Thank you. Thank you.